Hi, this is Brian Kim. I want to share with you case number 275 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So you can see this patient has a really small pupil, and it's a fairly soft lens, so I'm not going to use any pupil expanding devices. I'm going to viscodilate the pupil and then employ double chop, cross chop, and mechanical fracturing concepts and principles, pulling pieces up out of the bag with the chopper to perform a very efficient and safe lens disassembly and removal in this small pupil case. As you can see, this is a fairly small pupil. The lens is not terribly dense. Using the cotton tip to control the eye, I use a corneal mark which will help me to center and size the rexus. And you can see the pupil's just barely smaller than the corneal marker, which means when I viscodilate this pupil, I'm going to be able to make the rexus about the size of that pupil. I make a paracentesis incision first on the right side and then the left side, making sure I'm flat to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see this patient has some lash exposure. This is the left eye. So I take that speculum out, dry the surface, and then I place that paper part of the tegaderm to cover the lower lid. And by doing it this way, this minimizes the lash exposure to the field. This minimizes any oily debris that gets into the field as well. So it's a hack that my friend Michael Posner taught me. And so I'm able to have a better protection as I do the surgery. So that's intracameral epinephrine and then some dispersive viscoelastic to viscodilate. And then I use that same cannula to control the eye. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then I enter. Using the Morio microrexus forceps, I puncture the center, pull down, grabbing the right side of the tear, going around circumferentially. And I like that cannula because it helps me control the eye as I do the rexus. But also, if I feel like I have OVD egress, I can push some more viscoelastic simultaneously to help me with the rexus. Okay, finish off the rexus. Burp some viscoelastic out, coating the corneal surface with the viscoelastic. And this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. Because this is a small pupil, you have to be mindful as you push the BSS. You don't want to be overly aggressive. So I fill the bag, do the hydrodissection, lifting the lens edge up. By lifting the lens edge up, I'm able to decompress the bag, push the lens back down, and I'm able to get the lens to spin. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. You can see as soon as I did that, the pupil came down. And so, unfortunately, the viscodilation didn't work. I placed the chopper under the rexus edge contra-incisionally, the phaco-tip vertically sub-incisionally, fracturing the lens in half. That's double chop. Sliding the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip, and that is the cross chop. Placing the chopper around that lens piece again, under the right side, and I was able to hook the lens piece up out of the bag, and I start to emulsify it. Using some vacuum to lift that left side piece up with the phaco-tip, and then getting around it with the chopper, and then emulsifying that lens piece. And doing that once again, lifting that fragment up on the left side with the phaco-tip, and then crushing the lens piece in half and emulsifying it. using the chopper to tease that piece up into the pupil, emulsifying it, and then using the chopper to hook that piece on the right side and pulling it up out of the bag, loosening it up, using the chopper to tease it within the pupil, grabbing it with some vacuum, staying within the pupillary zone, the safe zone, and then emulsifying the lens piece. Removing the epinuclear material contra-incisionally, the thick epinucleus begins to collapse within the phaco tip, using the chopper to facilitate the removal of the epinucleus, using the chopper to grab the edge of the epinucleus and lifting it up. You don't want to bring that phaco tip deep in the bag when you don't have to. Better to use a chopper to bring the epinucleus up to the phaco tip. By doing it this way, you're not getting the phaco tip too close to the posterior capsule. All right, and the epinucleus tumbles right out. So I take the chopper out, push BSS in, take the phaco tip out gently, but decompressing first so that I don't have iris prolapse, and then placing the INA tip in, starting subincisionally, trying to peel the cortex from anterior to posterior, peeling the cortex on the left side and then the right side, switching to polish mode, polishing under the rhexis edge. And even though it's blind, it's okay because of this soft polymer tip. Very zonule friendly, very capsule friendly. Repositioning the patient because the patient's moved out of the field. Polishing the posterior capsule. I don't like pulsing BSS when I can't see the edge of the rhexis, so I bypass that step and go straight to the cohesive viscoelastic. And I'm not going to sweep for the same reason. This is a Bausch & Lomb LI61AO lens. This is the 2.4 millimeter injector. Do a two-handed technique as I inject and deliver the leading haptic into the bag. It goes down, which is actually quite helpful because I know it's going to go into the bag. The leading haptic's pointed down, but as the optic is delivered, it rotates back up parallel to the capsular bag plane. Deliver the optic and then deliver the trailing haptic. You just pull the plunger back and it engages the trailing haptic and it goes into the bag. Really nice injector. I love this lens, and it goes to that small incision. Again, the 2.4 millimeter injector. Removing the viscoelastic from within the bag. Removing all the viscoelastic from the anterior chamber. Using the Lester hook to make sure and double checking that both haptics are in the bag. That's another reason why I like the three-piece lens in these situations. When you have a three-piece lens in a small pupil situation, you know as the haptics go in, they expand and they're not going to pop out of the bag. If you have a single-piece acrylic lens in this situation, it is possible that a single-piece acrylic lens can pop out of the bag and then you can end up having UGG syndrome because one of the haptics is out of the bag. I've seen that from other surgeons who have referred cases to me for UGG syndrome. And so it's always good to check by retracting the pupil with an instrument like the Lester. But again, a three-piece lens, much less likely for that haptic to pop out as opposed to a single-piece acrylic lens. So again, a small pupil, I was able to employ double chop, cross chop, utilizing and leveraging mechanical fracturing techniques to divide the lens very efficiently by flanking the lens with the instruments and then using the chopper to hook lens pieces up out of the bag, as well as using vacuum to help me lift pieces up out of the bag. And so again, a very efficient lens disassembly in a small pupil case without needing iris retractors, iris hooks, or a pupil expanding ring device. So I hope this was helpful to you, and I thank you for your attention.